Good morning, good morning. Welcome to Wednesday Instagram Live, our first live for today, starting out with NYBRA. We're so excited to partner with them for Bra Day and share all of this amazing information. So please hold tight as we are waiting for Dr. Israeli and Dr. Feingold to join us this morning. And again, for those of you that don't know me, I'm Tracy, the founder of BRCASTRONG, and we'll do a short introduction once we get started this morning. Thank you. Good morning, Dr.
Good
Israeli. How are
morning.
you?
How are you?
I'm good. This is nice and early, right? Like rise and shine like you were going to the OR.
Yeah, I would be halfway through my first operation by now.
Oh, wow.
Oh yeah.
Interesting.
Yeah, so this is we're like halfway through the day already, right?
All right, let's just wait just a couple minutes for Dr. Feingold to
Sure.
join us.
Well, I
And
mean
then we will,
it's Breast Reconstruction Awareness Day. We're two-thirds of the way through Breast Cancer Awareness Day. Um, you know, and I guess we're going to talk today a little bit about history of mastectomy, history of breast reconstruction, right?
exactly. And know your options and knowing what's out there and what's available and how far we've come in the history of breast reconstruction, which I'm sure you can relate to very well.
Oh yeah, no, we've come a long way. I can tell you that breast reconstruction itself is now become a subspecialty of plastic surgery, and especially over the last 2 decades, there have been incredible advances. Uh, it's brought us to a place that's I never would have imagined when I was a medical student or a resident. Honestly,
You know, even since I found out in 2004 that I carried the genetic mutation, I'll never forget looking up like breast reconstruction options and just the information that was there to compare to today when you Google breast reconstruction options, right? There's like several compared to in 2004, there wasn't any. There wasn't a lot, I should say. It was really direct to implant or expanders.
yeah, I mean that's true. Was Google a thing back then?
Well, the internet, I should say.
Yeah, that's
Maybe
right.
it really wasn't known, but like we still had our phones, and I mean, I remember walking out and finding out that I carried the gene and just Googling, like basic information. And I remember, I think it was the Plastic Surgery Foundation. It was one of the foundations, and it just had like two or three options. There was not a lot of options. And I wish I would have screenshot it back then because I'd love to be able to compare, like what we really know in our community, like and how far we've come. But this morning, obviously, we have you and Dr. Feingold being able to share all that amazing
Yeah.
information.
Yeah, well, I mean, we can talk a little bit about, before we even think about the history of breast reconstruction, what's the history of mastectomy? Um, if you look back thousands of years, there were no really defined treatments for breast cancer. Women often neglected their disease if a lump was discovered because there were no real treatments. And it wasn't until late 1800s, late 19th century, where procedures were kind of defined anatomically, the mastectomy operation. Um, if you look back in the Middle Ages, they were starting to do mastectomies, and I hate to use this word, but it was really like an amputation. I mean, all of the skin was removed, all the breast tissue was removed. There was no anesthesia. Women would get infections, frequently would not survive the operation. Um, so it really wasn't until the late 1900s. Now we had anesthesia, surgeons understanding the anatomic sort of uh, uh, components of the breast to complete a mastectomy. Oh, there's Dr. Feingold. Good
Morning.
morning.
Good
Yeah,
morning.
I was just talking about how, before the late 1800s, late 19th century, there were no real options for treatment of breast cancer, and the mastectomy operation wasn't defined until the late 1800s. Actually, a surgeon, Dr. Feingold, trained at NYU in general surgery before he did plastic surgery. William Stewart Halstead was at NYU, wasn't he? And he was one of the first ones to define mastectomy as an operation, and that was life-saving at the time. But breast reconstruction, that was not even a consideration, back then.
Well, Halsted, who was famous for creating the radical mastectomy, which was very deforming, of course, he actually admonished surgeons about doing reconstruction. His famous quote was that you shouldn't do anything to repair the woman's breast after the surgery, lest it hasten the return of the breast cancer. So that was a misunderstanding about breast reconstruction, and that somehow would be dangerous for patients.
Yeah, and that misunderstanding really perpetuated itself through generations of surgeons. So, for almost 100 years after Halsted described the mastectomy operation, radical mastectomy, then modified radical mastectomy, that was the only surgical option for women, regardless of the size of tumor. And then less invasive approaches became more available, around the time that we were training, in surgery.
It's truly amazing to hear like the history and what's happened and the changes. But when you say that there was no anesthesia, like I couldn't possibly imagine going through a procedure now without anesthesia. How
Yeah.
did women, I wonder like how women reacted and how their healing process was, because it's so painful.
Yeah, remember that there was no anesthesia for any surgery. So, the advent of general anesthesia in the mid 1800s allowed surgery to advance as a field, and certainly breast surgery and mastectomy surgery. Other forms of treatment throughout the 20th century allowed us to do less invasive types of mastectomy. And as less invasive approaches to mastectomy, skin sparing, nipple sparing, preservation of more skin, reconstruction became something that was more possible, even avoiding potentially staged operations.
But I think breast reconstruction in its origins was not a finesse result, and there was a hope that the mastectomy itself would be less invasive, and that led to partial breast removals such as lumpectomy. So when you look at how mastectomy has changed over the years, you can't overlook that partial mastectomy became popularized in the 90s as a way to preserve a breast. Not that it didn't create some deformities, but women who had lump removals, possibly with radiation afterwards, might be able to preserve a breast, although nowadays we will even fix those breasts with fat grafting, for example, but it became established that that was as safe as total mastectomy, because that was certainly less desirable if the nipple was being removed. It took more years than that, maybe into the maybe just a decade ago, when nipple preservation became popularized. And there was some unknown risks there about whether or not that was going to put a woman in danger of recurrence of the cancer. But it's been very well borne out by European and American studies that a properly executed nipple-sparing mastectomy is as safe as the old-fashioned or traditional total mastectomies where the nipples were removed, and the aesthetics of the reconstructions are so much better when we have all the skin, including the nipple. And you can see how it's emotionally very appealing for a patient to have a hidden scar in the crease under their breast when they have their mastectomy.
Yeah.
If we can back it up just for 1 second, and I know we often talk about mastectomies, but we really don't talk about lumpectomies anymore. I feel like there's not enough information out there, because women often say, why do you have a mastectomy? Why don't you have lumpectomies? Personally myself, after undergoing 2 lumpectomies, then I decided for a mastectomy. But maybe if you can explain a little bit the difference between a lumpectomy versus a mastectomy to women.
Well, a lumpectomy involves removal of a portion of the breast, including the mass or the lump itself, and is indicated for women with tumors of a certain size that allows that procedure to be done. And as Dr. Feingold alluded to, when a lumpectomy or partial mastectomy is done, nowadays we offer the opportunity for oncoplastic approaches where a pretty breast shape can be preserved or achieved even with a lumpectomy. Although most women undergoing lumpectomy will also need radiation. So yeah, I mean, lumpectomy is less invasive than mastectomy. Skin sparing or nipple sparing mastectomy approaches are less invasive than old approaches to mastectomy. So, I mean, you were sensing a theme here. We're realizing that less invasive approaches still allow us to get good outcomes from a cancer perspective, and certainly from a plastic surgery, from a reconstructive perspective. For example, nipple sparing mastectomy procedures, as Dr. Feingold mentioned, now allow us to do direct to implant reconstruction. Right, so that's something that when breast implants were first described, going back to the history of breast reconstruction, when they were first developed, that certainly wasn't an option. I mean, that was back in the 1960s, right? Initially developed, used for cosmetic breast augmentation. In the early 1970s, that's when they were first used for breast reconstruction. And if you look back at the original papers in the literature on the utilization of breast implants, silicone implants for breast reconstruction, it wasn't really the best, by today's standards, it wasn't really the best outcome. But it was hailed as a triumph back then, because it really gave some hope for women that were facing mastectomy. And then of course flap procedures came about in the beginning of the 70s, the latissimus flap, then the tram flap, the DIAP flap in the 80s. But it's less invasive approaches to mastectomy, lumpectomy operations. Those are what allowed us to improve outcomes in breast reconstruction.
With the less invasive approaches to a mastectomy today, how did these approaches to breast cancer reconstruction change?
Well, a less invasive mastectomy is still a mastectomy. It simply allows hiding incisions in the crease under the breast and preserving the nipple without scarring the breast. The impact, as Dr. Israeli just mentioned, on implant reconstruction means that we don't often have to use tissue expanders anymore, and we can go directly to a final implant on the day of the mastectomy instead of a two-stage approach. And with natural tissue, we can simply fill the breast skin with body fat, and it really looks like no mastectomy has even been done. And it's really the combination of less invasive mastectomy with better outcomes in reconstruction that have really improved the appeal of mastectomy and reconstruction as a thought process for women. When you go back to the 90s, when lumpectomy became popularized and was proven safe, many women, of course, would prefer to avoid having a mastectomy at all. But it's interesting to see that in the 20 to 30 years since, there's been a shift back toward mastectomy in the minds of many women, especially younger women. And part of it is less invasive mastectomy and better outcomes in breast reconstruction. But part of it is also just psychologically being aware that all the breast tissue has been removed and you've eliminated future cancer risk from your life. So back then, Dr. Israeli and I saw many patients that were either interested in lumpectomy or single-side mastectomy to preserve a breast. Now it seems that the overwhelming majority of our patients, especially younger patients, would rather have that double mastectomy, eliminate their risk, have symmetric reconstructions, not have to have the continuous ongoing surveillance that's going to happen if you keep part of your breast and all of the other breast, a single episode of care, and it's done, for the rest of your life. So remarkably, while you wouldn't think that women would want to have a double mastectomy, it's now the majority of our patients, and I can see how it achieves peace of mind for them. And that really, goes a long way to give them quality of life.
Yeah, and I think that that's driven actually by, I mean, I say this all the time, it's driven by the quality of the reconstruction, right? So, when we first started our practice, more than 20 years ago, the quality of reconstruction was not what it is today. So it was a little bit more difficult to kind of take that leap, make that decision to remove a healthy breast. Let's say if somebody's diagnosed with breast cancer on one side, and I want to remove the healthy breast, or do a risk-reducing procedure on both sides, if the quality of the reconstruction wasn't as good as it can be. And I think that the quality that we can achieve today, particularly with natural tissue flat breast reconstruction, but also with implant reconstruction in many cases, that makes that decision easier. And yes, that is the trend. The majority of women that we do reconstruction on in our practice, it's bilateral, and that's been an evolution. And I should say that if we're kind of going back and talking about the history of this, the ability to determine genetic risk also helped sort of usher in that era of decision making toward bilateral mastectomy, because now you have women that know that they carry a genetic mutation that puts them at higher risk, and to get the peace of mind, it requires a bilateral procedure. So women are younger and younger now presenting to us for risk reducing surgery.
We talk about nipple sparing, right? And I'd love to hear some more history on nipple sparing, because I feel like, yes, we're offered it. Like, when was it started? When did we really come and start to do this procedure more?
Yeah.
Well, we didn't start to do it here in the United States. I think it was popularized in Italy and in Great Britain before American surgeons sort of reluctantly accepted it and started performing it. In Europe, they would remove the breast, keep the nipple, and sometimes do intraoperative radiation therapy to the nipple. And while that's not standard treatment for nipple-sparing mastectomy, certainly not in this country, they do biopsy the tissue directly underneath the nipple and send that for its own independent analysis to give everybody confidence that keeping the nipple is not keeping any breast tissue, or not enough breast tissue that it would put someone at risk, and certainly not keeping a breast cancer, in the patient. So it's certainly within the last decade that it's become popularized in the United States, and it may not be for everybody. We will have patients that say, I understand it's proven to be safe, but it still makes me concerned. I want maximum risk reduction, and patients will make an informed choice. They just need to be given all the options and understand that there's more than one correct choice. It's not like one's the right choice and one's the wrong choice. There may be more than one appropriate way to treat it. Some of our patients with gene mutation, for example, are offered nipple sparing because they don't actually have cancer, and they love to hear that. But some of those patients will say, well, but if I have high-risk breast tissue, if anything's left behind, maybe that's going to put me at high risk. And some of those people will say, I'd still rather remove the nipples. But if a patient goes that route, we still have excellent techniques for nipple reconstruction. And so between making a nipple and a high-quality 3D tattoo, there are outstanding results in nipple reconstruction. So that's not necessarily a second place result for somebody. It may be exactly what makes them comfortable, going forward.
Yeah. So simultaneous with nipple sparing mastectomy, nipple preservation becoming sort of popularized in the United States. Skin sparing mastectomy, preservation of most of the skin with the removal of only the nipple, is something that also is not. It's not been around for as long as you might think. But it's the concept of preservation of the soft tissue that allows us to achieve maximal outcomes in breast reconstruction. And that's really been over the last couple of decades. So breast reconstruction itself is really a new specialty. It's close collaboration with the breast surgical oncologists that has allowed us through the years to develop and improve outcomes as techniques and as technology has advanced.
One of the girls said Angelina Jolie had nipple delay procedure. What's the difference between that and nipple sparing?
Actually, it's not. It's nipple delay procedures is part of a nipple sparing approach. So, when we do breast reconstruction, when a mastectomy is done, one of the key factors that we take into consideration at the time of surgery is the quality of the soft tissue envelope, the skin that remains, the viability and the blood supply to that tissue, especially to the nipple areola. And one of the basic principles in plastic surgery is the delay procedure. What that means is that we do an initial procedure in preparation for surgery, perhaps a couple of weeks before the mastectomy, for example, where we partially divide the blood supply to, in this case, the nipple, and allow that to heal in the 2 weeks or so prior to surgery. And that it axializes the blood supply to that tissue, or it improves and increases the blood supply to that tissue during that 2-week healing period. So that when we're now going to surgery for the mastectomy, that nipple, which had a delay procedure, has a much better blood supply. It's a little hardier. And that means that you're going to decrease the risk of problems of wound healing, decrease the risk of loss of skin, maximize the ability for that nipple that's preserved to survive. So she had a nipple delay procedure. It allowed the surgeons at the time of mastectomy to have a higher confidence level that in her case, and I don't know what her situation is, everybody's different, we don't always need to do this, but occasionally I will do that as part of my surgical plan. They had higher confidence that her surgeons, that the skin envelope would be healthy and viable to allow a safe reconstruction. I don't know if you have anything to add to that, Dr. Feingold, as far as that.
Well, I think when nipple sparing procedures were first being tried, there was uncertainty about whether the nipple would survive during that mastectomy process. And by doing a partial separation of the breast from the undersurface of the nipple before the mastectomy, that gave the nipple time to get better blood supply, so that when the total mastectomy was done and all the breast tissue was separated from under the breast skin and the nipple, there wouldn't be problems with the nipple not surviving the operation. But now that there's been improvement of experience with nipple sparing mastectomy, and incisions at the time back then were often done around the nipple, whereas now we tend to do nipple sparing mastectomies with hidden incisions in the crease under the breast, which is actually less damaging to the blood supply to the nipple. We find that we don't need to do nipple delay procedures to the degree we used to many years ago. So it was not that unusual when we started doing breast reconstructions for women who were having nipple sparing mastectomies to do their delay procedures, sometimes in the office, sometimes in the outpatient center, a couple of weeks before their mastectomy. Now it's more uncommon that we would really need to do it. Perhaps if someone is a heavy cigarette smoker, a diabetic, somebody who's had radiation therapy to the breast, previous scars around the nipple, then we might have that conversation again about whether it's a helpful first step prior to mastectomy. But so many breast surgeons have developed expertise with nipple sparing mastectomy, so the nipple delay is not nearly as common a procedure as it was when Angelina Jolie's surgery was publicized.
No, it's interesting. We all always go back to like Angelina Jolie's story, right? And the education of like what she's done compared to others. And I think it's interesting, and you guys probably can relate that in different states all over the world, everybody does this procedure so different. You know, like I said to Dr. Israeli before, you know, there's really no gold standard for breast reconstruction. And that's really how I feel, because you can see 5 different doctors and get 5 different answers. Mind you, you guys are all in the same field doing the same thing.
Yeah. Well, I
I
mean,
thought we were,
I
I
think
thought
there's
we were
no,
the gold standard.
what's
What did
that?
you say?
I said I thought we were the gold standard in
Well,
breast
I do
reconstruction.
have to say, and that's really the reason why I decided to do Bride with you guys and partner, because when we talk about the options or knowing what's out there, the history, like we need to really be informed, not only like on our options, but how far we've come in making these procedures work. You know, when I found out again and I started my surgical journey, there was no nipple sparing mastectomy, there was no hidden scar, there was no flaps. So these conversations are imperative as long as you have a group of physicians like yourself that have the gold standard, that have programs in place. Like how many, and you guys probably can answer this good, how many practices have implemented the programs that you have? There's
I,
no empowerment programs. There's no, well, let me hold your hand and walk you through the process. And I think that if more women had that, we wouldn't face so many revisions or so many complications, or and just know what we're up against and the real facts that can happen.
well, look, I think Dr. Feingold and I are both the founding partners at NYBRA Plastic Surgery. And you know, early on when we started our practice, you know, the the Women's Healthcare Rights Act, right? We should talk about that. The Women's Healthcare Rights Act is something that was signed into law in October 21st of the third Wednesday of the month, which is why we're celebrating or recognizing, you know, Breast Reconstruction Awareness Day today. But that was in 1998. Right. So think about that. Dr. Feingold was in practice for a few years. I was in practice for 1 year. You know, we had joined together in practice. This law all of a sudden increased the need for quality breast reconstruction services because there was all of a sudden an increased demand. You know, when I was in training in New York in the early 90s, breast reconstruction was being done, but not that frequently. You know, it was frequently just women that could afford to do it. So this really revolutionized breast reconstruction as a subspecialty. Dr. Feingold and I particularly enjoyed doing this type of reconstruction for a number of reasons. You know, we were there at the forefront offering, you know, the newest techniques. You know, when I joined Dr. Feingold in practice, he was among the first surgeons in the country routinely doing free flap breast reconstruction. So that became a core of our practice in the region, in the New York area. So not just in the New York area, but in the country. And through the years, as you know, options developed, we were among the first to do direct to implant reconstruction. Certainly among the first to use dermal matrix products to improve outcomes in breast reconstruction as early as 2001. Incorporating fat grafting as part of the reconstructive practice. You know, we were in the forefront of doing that. Pre-pectoral breast reconstruction, pre-pectoral conversion, again, among the first to do that. So, you know, I think that you ask how many practices do this. I think that it's important to recognize breast reconstruction as a subspecialty. It requires a dedicated approach. We've grown over the past 2 decades now, 5 surgeons. It's myself and Dr. Feingold and Dr. Peter Korn, Dr. David Light, Dr. Jonathan Bank. You know, we're able to offer the gamut, the whole spectrum of options for breast reconstruction. Most recently, over the past couple of years, you know, sensation preserving mastectomies and reinnervation procedures. So, you know, you want to look for a practice that offers all options, excuse me, because every woman is different, and as the history of options, you know, progressed, and we started to incorporate these procedures into our practice, we can offer, you know, depending on the individual, what's right for her. And you know, I think that if somebody's kind of dabbling in breast reconstruction or just offers implant reconstruction and not flap reconstruction, you're not going to be getting, as a patient, an unbiased opinion as to what the best operation is for her. And sometimes, you know, I had a patient yesterday all of the options. I said, you can have an implant, you can have a flap, you can have an abdominal flap, you can have a tug flap. You know, we said, you have all the options. Sometimes that's even more difficult. But that's I think the core of what we were trying to provide here at NYBRA Plastic Surgery. And there are practices around the country that do that, but honestly, it's you know, not that many.
Right.
But I think you just have to have a commitment to taking care of patients that are going through difficult diagnoses and difficult decision making. And when you can provide care in a supportive environment and show them that there are many different options, we're not biased toward any one particular operation, but by offering the full spectrum of approaches, patients can decide what they're most comfortable with. Sometimes it's obvious to them within minutes of arrival that they know the type of reconstruction they want to have, and some people find it a bit confusing. So we've provided a lot of resources to them with online education through our early pilot project with breastreconstruction.org as an educational website for women, so they can learn about different operations and review it at home, because sometimes when you're given a frightening diagnosis and you come for a consultation, it's hard to remember what you've been told during a consultation, or you get confused in terms of the different options. But if you take your time with your patient and give them the information they need and give them the emotional support and give them time, then it usually the fog lifts after a while and it becomes clear, and they know what they want to do, and then we can really help them with any number of different procedures.
Yeah, and I think I just saw Molly Sugarman just joined, you know, and Dr. Feingold can speak about this as well. You know, early on in our practice, we realized as we got busier and busier doing breast reconstruction work, that, you know, it's more than just an operation. It's the emotional component of making the decision to have a mastectomy, a recent diagnosis of breast cancer that women, you know, are dealing with, or the decision to undergo risk-reducing surgery. All of these emotionally charged decisions, sometimes it's hard for us as surgeons to fully provide the proper support. That's the reason why we had Molly Sugarman join us all those years ago, and she developed our patient empowerment program, which provides tremendous support services for our patients, and she'll evaluate every patient that comes in for breast reconstruction services. So I think that that is another sort of feature. You know, going back to history here, I think this is an evolution. Nurse navigators in the hospitals, that's developed over the last, you know, couple of decades. I'd like to think that our patient empowerment program that Molly developed, probably among the first in the nation, is really something that's unique, and that's part of a paradigm shift in how we treat women that are facing mastectomy.
And I have to agree, you know, talking about like the team approach, you know, going through and having the support, because obviously you guys are physicians, you see a lot of people, but like having somebody to be able to hold your hand and give you tools, not just for you, but for your caregivers, for your family, you know, to help them implement and make decisions and have them by their side. I think having that group can change a woman's life, because it's not an easy decision, as you guys know. So having that support is imperative, and knowing that you can call Molly and Molly can guide you through it and give you different avenues, I think it's a huge piece of this puzzle, because it's not just going in and getting breast reconstruction. Like you said, it's the physical, the emotional, and everything else that goes along with it. And one thing that I've learned from Molly is, you know, all the different guided imagery and meditation she's done. I mean, it can change a woman's life. It can help you get through and be able to process and stop and think, where, you know, we either find out we carry a gene, we're going to be proactive, or we get a diagnosis, but when do we stop and think about and take that time just to clear our minds?
And we made a decision many years ago that we wanted to be a comprehensive program for women who needed these operations. So it really required addressing all of those emotional needs and providing that programming, providing education, providing full spectrum of operations, and cutting edge operations, and having an open mind about changing techniques, both in the mastectomy and in the reconstruction. And so, as Dr. Israeli said, our practice itself has been in evolution all of these years. And the way we do it today is very different than the way we did it 10 years ago or 20 years ago.
Now, what do you guys see coming down the pipeline? Now, I follow, all different clinical trials and different research and, in different countries as well, because obviously some other countries have different advancements. And one thing that I've always questioned on, if you guys could maybe touch on, is robotic mastectomies and reconstruction. Like, do you foresee that being an FDA approved and making history, or do you see another form of a mastectomy being developed?
I think you're going to have to ask the FDA that. In particular, the FDA has been slow to allow the progress of applying robots for mastectomy. There was a little publicity a few years ago about a couple of robotic mastectomies, and there was also some concern about the application of robotic surgery in certain cancer operations in terms of safety. And so they definitely put a halt on approving that. And I'm sure there are trials in progress. It's unclear what the relative, merits are. We definitely want, first and foremost, to have as close to a curative operation as you can have. Otherwise, getting ill again with a beautiful reconstruction is not helping the patient. So we're just going to have to wait and see how that progresses.
Yeah. I mean, if I had a crystal ball, I would predict that the relative advantages or presumed advantages of that approach, it won't bear out as anything really substantive when you look at the quality that we're able to achieve now with hidden scars in many cases, and allowing us to do an oncologically safe procedure. So I'm not sure the need is really there to utilize this additional technology. But you're asking me to predict, so time will tell with regards to that. So what else do we see down the pike in the future? How about a cure for breast cancer? Then we won't even need to do any of the things that we do, right? So, that would be the ideal future. And the truth is that treatments have improved oncologically as well. Historically, just as approaches to mastectomy have improved, and approaches to reconstruction have improved. So, yeah.
Well, before we end, I know that this evening we have another call with your three amazing other partners, Dr. Light, Dr. Korn, and Dr. Bank, to talk about Know Your Breast Reconstruction options. And I want to thank everybody for coming on today. Dr. Israeli, Dr. Feingold, thank you for your dedication and time to making a difference and sharing the experiences and sharing what's going on and how far we've come in our community. I really feel that this information is imperative because obviously as times have changed, things have changed, the way technology has grown, and we now have all these advanced technologies to be able to help women in the community. And I know my job at BRCASTRONG is to make sure that you know all your breast reconstruction options, you know what's going on, you know about amazing practices like NYBRA, who have a commitment and a dedication to making a difference in our community. And I truly believe that your physician can help you make that difference. Because if you and your physician are on the same page, you guys can go together and make that difference in your life. No, everybody knows it's not an easy decision, whether you're diagnosed or you're taking preventative action, but just knowing that you have your breast reconstruction options and knowing that there's practices out there that want to continue to make a difference and that want to walk you through the process. So,
well, thank you for what you do. And thank you so much for having us today.
Of course. And
Thank you for improving our ability to reach more women with education. And we look forward to hearing tonight's interviews as well.
I'm definitely excited. Of course, know your options. And, as we're closing out, I do want to let everybody know that at BRCASTRONG, we offer pre-mastectomy care packages. So if you are headed in for a mastectomy and are looking for support, you can please reach out to BRCASTRONG. NYBRA is one of our sponsors and has helped us sponsor packages to women who are headed in. These pre-mastectomy care packages include robes with drain holders, post-mastectomy bras, and pillows. Again, it's just not about the physical, let's go in. It's about the emotional comfort when you come home that we want to provide to you. So I see there's a couple women that are scheduled for mastectomies. If we have not helped you or you're interested, please feel free to send us a message, or you can reach out to myself directly. I hope everybody has a fantastic day, and I look forward to seeing everybody this evening at 7 o'clock.
Thank you.
Thanks, Chris.
You're welcome.
Bye-bye.
Bye-bye.